how does continuity start, and what pain points do you guys see? Because you're really impacted when you do have those returns to hospital. So if you could speak to that.
Yeah, so first off, I'd like to echo what everyone is saying. Specifically, Allyson, you touched on all of the points that I was going to discuss. I think communication is, foundational. But I think from an acute care perspective, I think hospitals always think they're doing a great job, right? Until you follow that path with the patient all the way. And I think it's misaligned communication. A lot of the disjointment that I see is, we have great relationships with all of our post-acute care partners, but when you really think of what's happening, at least here in Carson City, is we're making the referrals, we have the shared EMR, we think everything's open and available, but then you have someone almost coming in from the home cares or the skilled facilities, almost, I hate to say, but from a marketing perspective. And what we tell our partners on a continual basis is, I don't need to be marketed to, I want to know how we can actually help. So it's the continuity needs to have someone that is not under their own requirements. The skilled facilities have requirements, the home cares have requirements, the hospitals have requirements, and everybody is trying to ultimately do the right thing, but we're also managing our compliance and our metrics. So I think that really what falls to the bottom is the patient, unfortunately. Even though we all have the best intent, we're keeping our eye on everything else. So it is communication. I think it's just oftentimes misaligned.
Thank you, Karen. And I'm going to actually keep the spotlight on you for a minute. You'd mentioned the word metrics, and that kind of goes to our next question, which I'm going to circle back around, kind of back around the horn. When you're looking at discharging a patient, and what is success and what is failure in that setting?
So from the acute care side, it is return to acute care hospitalizations. It's overutilization of the ER touches, how frequently they're getting in to see their PCPs. So it's hospital-based metrics, and it all ties back to reimbursement. So I think I think you can be successful financially, but you have to put the quality of the care first to drive those financial impacts. And when we're looking at, like you say, very quick length of stay, our average length of stay is about 3 days in the acute care, and that's a lot to swallow for the complexity that we're seeing. So we've got these patterns in place, but we're really managing and looking towards utilization levels, length of stay, readmission rates. So it's primary numbers.
Thank you. And but Allyson, what is the success or failure metric that you guys look at from the skilled nursing environment?
Well, unfortunately, the only metric that we really have available is the return to hospital from the skilled nursing facility. We have a lot of tools that will look at that, and we can drill down to diagnosis, a lot of different components that we can look at. There is nothing really that we have to help us to gauge anything after that when you go to home health or to assisted living. Once they discharge to a community setting, we don't a lot of times hear about it until they're back in the hospital. And then we get a call from the hospital going, oh, so-and-so's here. And we're like, oh my gosh, we just discharged him 3 weeks ago. Now we're being held accountable. And even though we're not financially dinged, I guess is the best word, like the hospital, there's no like financial penalties for us per se, but there is, because the hospital will say, we'd like to admit to you more, but your return is so high that, we really like you. However, our metrics say that you're riskier than, say, your competitor has a much lower return to hospital rate than you do. And we all know that for that first 30 days after discharge, we're responsible. I mean, that's regardless of what happens in the community. And so I wish we had better metrics to help us gauge what happens after discharge into the community.
Thank you, Ally.
Mm-hmm.
Sheena, I know it's a different environment. I'm not sure. I'm actually less familiar with the home health environment, but I'm getting more familiar with it. What are the metrics that you guys use regarding continuity of care, and what is a success in that setting and what is a failure in that setting?
We have many metrics that we have to follow up on. So everything we do is scored and looked at by CMS. Washington specifically became part of a pilot program in 2016. There was 9 states part of this program called value-based purchasing. So we are financially penalized if we have patients that either return to the hospital. We're scored on our ACH rate. We're scored on several different pieces as far as medication reconciliation, whether they're on physical therapy, and let's say we admit them and we score them at a certain point, we need to get them to their baseline, otherwise we're dinged for that. Timely initiation of care, it goes on, and we're star rated as well as financially rated. We work closely with a lot of skilled nursing facilities. If, let's say, we see a patient that came from them, they're failing, rather than returning them to the hospital, we'll work with that skilled nursing facility to get them back in within 30 days. We also do work with hospitals quite a bit when it comes to ERs. We utilize dispatch health a lot to avoid any preventable rehospitalizations that can be taken care of in the home. But we are heavily scored and looked at when it comes to outcome metrics and quality.
Thank you. That is enlightening. And Kristen, I know also a different environment, different set of responsibilities, but in the home care environment, what does it look like in terms of, do you guys have any metrics that you keep, and what does failure look like? What does success look like? I mean, I'm sure you keep metrics, but what are the ones that you are looking at as success and failure?
Well, that's success and failure metrics based on this conversation is something that home care is starting to understand the importance of, and educating the people around us of how we do keep track of, whether it's clients. You know, when we take on a new client, we can let our team know, and our system has a way of tracking, were they given to us because they were discharged from a hospital, sent home from a skilled nursing, or were they continuing, care needed in the home or in a community. So we can track where they're coming to us. We can also now track, and are starting to track, things like falls, trips to the hospital. So when you talk about returning to the hospital, how many times has our client gone in the last 30 days, 60 days, 90 days? And that allows us to start the conversation with people like all of you. Karen, did you know that we are able to, have the conversation? We are able to decrease fall risks and stop this revolving door in and out of hospitals. And if you educate our clients and help them to understand that more monitored safety risk, having a caregiver there helping them walk on their own or shower on their own will prevent a fall, and therefore prevent going back into the hospital, to the skilled nursing, needing home health, that constant revolving door. So I think it's within home care specifically, it's letting people know what we're capable of doing, and showing the metrics behind it. So that means we need to track it. That doesn't just allow us to be lip service, but allows us to give an actual reason why we are beneficial in this whole healthcare process.